Thank you very much, sir. Before we take question answers from others, we have one resident doctor, Dr. Kirtan, who would like to present a case and need your opinion.
Yes,
Dr.
sure.
Kirtan, can you share your screen?
Yes, sir. Good evening. I'm actually unable to share my screen, sir. The host has
Siddharth, can you?
Yes, sir. I've made him the co-host now. Yeah.
Yeah, Kirtan, now.
So, am I audible?
Perfect.
Good evening, everyone. I am Dr. Kirtan from Sri M P Shah Medical College, a general medicine resident. Thank you for inviting for this hematology masterclass. So here we go. On 10th of January, a 20-year-old female patient presented with complaints of fever, fatigue, breathlessness, and vomiting and abdominal distension. She had no complaints of bone pain, joint pain, skin rashes, bleeding, jaundice, or hematuria. Her past history was she had an episode of jaundice and once in the childhood, and the rest of things were normal. She was a vegetarian per se. Yeah. On examination, everything was normal except she had pallor.
Kirtan, can you be a bit slowly?
Yeah. On examination, she had pallor, icterus, upper abdomen. Liver was just palpable and firm. Spleen was moderately enlarged and firm. This without conditions which the patient was subjected to. Hemoglobin was 4.4. Platelet was 69,000. WBC was 5,100. MCV was 96. APTT was increased and even INR2. LDH was significantly raised, 1,794, and retic count was 3.1%. DCT came positive. The urine arm was normal as per se, except he had trace amounts of protein and RPCs. Hemoglobin was absent, and serum bilirubin was also increased. That indirect component being 8.
Go slow, go a little slow.
Huh.
Go back, go a little.
Yeah.
Slow.
As a
just go back to
the plate.
Okay, so let's look at
Samir sir, your voice is breaking.
Okay.
So yeah, hemoglobin was 4.4, platelet 69,000, hematocrit was 13, WBC was 5,100, MCV was 96, APT and PTINR was raised, retic count of 3.1%, LDH of 1700, serum bilirubin was raised with the indirect component of 8.2, DCT came positive and ICT was negative. There was no hemoglobinuria, and D-dimer was significantly raised. Right, the rest of the things were normal. So the peripheral smear, it showed macrocytic and normocrotic anemia with autoagglutination of RPCs. The final impression was that of a very immune-mediated hemolytic anemia. So this is a set of investigations.
So you had just a moment, Kirtan. So you had anemia, thrombocytopenia.
Yes, sir.
High retic count, high bilirubin,
Yes,
DCT positive.
Yes, sir.
And hemoglobinuria with high D-dimer.
Yes, sir.
Right. So this is the conclusion.
That's PT prolonged.
Yes,
yeah,
and prolonged PT.
Yeah.
With low serum albumin.
Yeah.
Okay. Fine.
2.8%. Yeah. So the peripheral smear showed a macrocytic and normochromic anemia with autoagglutination of RBCs. The rest of the things were normal. There was thrombocytopenia.
Okay.
Viral markers. No schistocytes, sir. No schistocytes. Viral markers were negative. TSH was severely suppressed with a high T4. The CD4 count was very low, only 65 cells per microliter. Hemoglobin electrophoresis showed HBT Punjab rate. We have previously done this Ham's test and sucralosis test, which was negative. USG abdomen showed hepatomegaly of 15 centimeters and splenomegaly of 17.4 centimeters. 2D echo showed moderate pH, and rest of things were negative. Yeah. So this was a working diagnosis previously, like autoimmune hemolytic anemia, thrombocytopenia, with HBD Punjab trait, query Evans, query hypersplenism, query aplastic anemia with a moderate PAH. So we treated the patient with IVIG 20 grams per day for 5 days, injection methylprednisolone 500 pulse steroids for 5 days, and then prednisolone in a tapering dose for 4 weeks. The packed red cell transfusion was given 5 units, vitamin B12 and multivitamins, tablet pneumococcal. So at the point of discharge, the patient had a hemoglobin of 10.7 grams, total leukocyte count of 1900, and platelet of 28,000. Then we referred the patient for a hemato-oncologist. On 10th of February, previously the ANA was negative in our setup at an outside private lab, which was ANA was done by an indirect immunofluorescence technique, and she came, she had 3+ positive in a homogeneous pattern. The DCT was positive, and the LDH was again raised 310, right? And the rest of things were normal. Retic count was 2.99, and absolute retic count was 103. Was marginally raised 103 into 10.9. Rest of the retic count indices were normal. Aspiration report showed adequate erythropoiesis, normal myelopoiesis, few megakaryocytes were seen. The differential counts and everything were normal. We were awaiting the refined biopsy report. So on 22nd of February, the patient came for a follow-up visit with the refined biopsy report. The report showed hypercellular marrow with not. Yes, sir.
I'm audible, the investigations.
Should I take back the slides?
Repeat the question. I think it was not heard.
Yeah. Hello.
I think you can go ahead.
Okay, sir. So this was the refined biopsy report. It showed a hypercellular marrow with a normoblastic erythroid hyper.
Please do that.
I think Samir, your voice is not heard. Okay. PT, APTT were not repeated.
What is it connected to?
Kirtan,
This no sir, no sir. The first time we were repeated, the patient actually didn't came us for the next time. She went to a hemato-oncology visit, and after 1 month she comes back to us. It was repeated PT, APTT, INR.
so they were normal, or when it?
The next time we repeated them, they were normal, sir, pretty normal.
Okay.
Yes, sir. Yeah. So we had repeated the CVC at this point of time. The patient had actually completed the tapering dose of prednisolone, and her hemoglobin was quite stable of 11.7. Platelet was 48,000. WBC was 2,500. HCT was 34.6, and MC was 87. And thyroid profile with neomercosal 20 mg, the TSH and everything was stable. So as the patient had ANA positive from an outside report, we subjected the patient for the entire ANA profile, and she had PMSCL and CENP positive, which are seen in the systemic sclerosis part. Yeah, from the follow-up visit, the TSH raised and free T3 was suppressed. So we put down the pneumococcal, and once we have completely omitted pneumococcal once the patient developed signs of drug-induced hypothyroidism. This was 3 weeks down the line. After the patient has completed the prednisolone tapering dose, hemoglobin was still stable, 11.7, and platelet was 48,000. 2 months down the lane, 26 May 2021, the patient presented with breathlessness, vomiting, fatigue, and abdominal distension, a hemoglobin of 5.2, and WBC of 6,800, and platelet 118,000. We gave a 3-point PCV, methylprednisolone for 5 days. Omnocortil was given for 7 days, and discharged with a hemoglobin of 8.6 and platelet of 90,000. Patient comes for a follow-up visit on 7th of July, that is 3 weeks after this. The hemoglobin was still stable at around the same level of 7.7, platelet of 47,000, MC was 99. MC was from the beginning, it was being on the higher side, near 96, 97, and 99 when compared to the hemoglobin fall she had. And then the TSH profile was pretty normal. We have completely omitted this pneumococcal since 1 month, and the TSH profile, she was off any anti-thyroid medication, and the thyroid profile was quite stable. But yet again, 3 weeks after that, the patient presented with breathlessness, fatigue, abdominal distension with an hemoglobin of 44.1. Right, she was off prednisolone since 3 weeks, and injection methylprednisolone was given for 5 days. 2 PCV given, and 5 days after completing the methylprednisolone pulse dose, the patient's hemoglobin is still 4.8 on 31st of July with a platelet of 17,000. USG showed splenomegaly with portal hypertension and glossositis. So points for discussion. I would like to comment on the probable etiology, underlying etiology, query autoimmune, query hypersplenism, query immuns with immunodeficiency. What will be the further line of management from this point of time, and what better could have been done for the patient? So with this, I open the discussion for expertise in the group. Thank you so much.
I think Samir sir has again internet issues. Sandeep sir, you want to comment till that?
This is associated with there is no doubt about autoimmune hemolytic anemia, but I think associated hypersplenism is also there because of cirrhosis and portal hypertension. And that's why platelets are I think never have become normal.
Yes, sir. Samir sir, your comments?
Yeah, I'm extremely sorry. I lost. There was a bad internet connection, so I missed his whole gather. I saw that the patient had come with the hemolytic anemia, and he had a markedly raised APTT, and he had a shrunken liver with cirrhosis and portal hypertension related hypersplenism, and therefore pancytopenia.
Yes,
and I thought I saw that the ANA was positive. So probably, this patient probably had an antibody against one of his coagulation factors as well. The commonest is factor 8, but it could be factor 9 sometimes. And therefore, the APTT was probably high because of that. And when you treat these patients with immunosuppression, all of that may normalize. But this can sort of recur again. So I wonder whether that is what the gist was. So what happened in the end? How did the patient fare in the end?
Yeah,
so that patient had 2 times repeated in admission again with the same complaint, recurrent anemias, and again on the second time treated with the IV steroid plus oral steroid, after which the hemoglobin and 3-unit transfusion, which the hemoglobin was just reaching 8 or something. But again, 3 weeks later, she presented again with the hemolytic anemia.
Yeah. So in this case, I would give rituximab as my next best drug of choice. Rituximab would be my drug of choice. Did you give him that?
No, sir. We actually didn't give rituximab this patient.
So that is what
you must.
Yeah.
Okay, so in AIHA, those who are resistant to steroids, the next drug of choice is rituximab. Most patients will respond well. You typically give a dose of 375 milligram per meter square once a week for 4 weeks, and then it has a long-lasting effect many times. If you have a good response, then you can always repeat rituximab at the time of relapse. The third choice, treatment of choice, which is difficult in this particular patient, but in any other patient, beyond rituximab, the next treatment is splenectomy. Okay, somehow as against an ITP where splenectomy can be deferred nowadays, you tend to use the other immunosuppressants. The other oral immunosuppressants such as azathioprine, mycophenolate, they don't tend to be all that effective in AIHA, and therefore splenectomy is usually the next best treatment. So here that is difficult because the patient already had cirrhosis, portal hypertension. Splenectomy is not easy to do in these patients. Okay. So I would definitely treat this patient with rituximab.
The next question, what Kirtan was asking, in the previous management, could have been done something better, or the better management, like in the first time steroids were given for a longer period, second time it was given for 7 days, and then we had the third relapse.
Okay, so
is it
so even in
regression or
AIHA,
something?
yeah. So in as against ITP again, in where you give steroids typically for a short period and then taper it rapidly. In AIHA, it is very important to give steroids for about 4 weeks at full doses. That's 1 milligram per kg per day, and subsequently the tapering must be slower. So you tend to taper down to a dose which will not cause much of toxicity, such as something like 10 milligrams, and then give that for a much longer period, something like 6 months to almost a year, and stop it only when the patient is consistently maintaining a good hemoglobin. So you have to give a prolonged course of steroids. So I think that's the only change that I would have done.
So second thing, Samir, here a lot of people, if you see the first line therapy, what they have used is 5 days steroid and IV gamma globulin.
No, not at all. No. I would not give immunoglobulins in AIHA unless, yeah, it hardly, I mean, of course it can work to some extent, but it's not an effective modality. It's not as effective as in ITP, and IVIG is not what I would use for AIHA. Okay, so you use steroids and you have to, as I said, short course will never help. You have to give a long course.
Again, sir, next question would be, in the third relapse, would you still give the steroid and then give rituximab, or you will give both simultaneously?
Yeah.
Or
yeah. So that's a good question. Rituximab takes, the median time to response for rituximab is 4 weeks. Okay, so you start the dose today. Today's dose will be effective after 4 weeks, and the 4th week dose will be effective after another 4th week. So it takes typically at least a month for rituximab to start working, and therefore during that period you need some bridge, and therefore we often give steroids to bridge that period.
okay, any other question, Kirtan?
Nothing else as of now, sir. Thank you so much.
Okay, thank you, Kirtan. Other question, sir, that has been asked by the participants is there a possibility that LDH is normal and there could be hemolytic anemia?
Yes, that can happen if you have it won't be stark normal, okay, as in less than 200, or you won't have those kind of values. That would be very unlikely, but you could have a very mildly raised LDH, and that is possible when you have a very low grade hemolysis going on. Okay, so typically sometimes in the say a hereditary spherocytosis, where it's a low grade chronic hemolysis going on, you won't have a floridly raised LDH. So you can have that situation, but it won't be normal. It will be at least slightly raised.
So next thing is, what you have said is, even if the patient has jaundice or bilirubin more than 10, you can give the PCVs in case of AIHA, right? So what
Absolutely.
will be your cutoff transfusion, sir? What level of hemoglobin you would like to achieve in a patient with AIHA by transfusion? Yeah,
so that depends upon the patient's condition. So if the patient is unstable, as in hypoxic, or having giddiness on standing and things like that, where he's decompensating for the level of hemoglobin, only then would I transfuse the patient. But I am on the I wouldn't wait till the patient goes into CCF and has a cardiac arrest either. Okay, so you can be liberal. You have to talk to the blood bank and explain to them that this is only in vitro incompatibility. In vivo, those RBCs will not lyse intravascularly. You won't have the complications of mismatched blood transfusion. So you can very well transfuse any unit of blood. Don't waste time in trying to find a compatible unit. Sometimes they spend a few hours in trying to find a compatible unit. Tell them just cross-match 4-5 units, whatever is least incompatible out of that, issue those. If you don't find a least incompatible blood and everything is incompatible, just issue any one of those. Now, sometimes you can't identify the blood group also, because they get so rapidly agglutinated, you can't even do a blood grouping. And in that case, you can just issue either O negative or O. If you know that the patient's blood group was a positive, you can issue just O positive blood.
Okay, sir. The next question which has come is, sir, what is DCT negative AIH, or when you say it is DCT negative AIH?
Yeah. So DCT negative AIHA is seen when commonly it is seen when you have to have a certain number of antibodies on the red cell surface for the DCT to be positive. Okay, so if these antibodies, if you have only a few antibodies stuck to the RBC surface, but they are potent antibodies. So even a few of them can actually cause hemolysis. You will have the hemolysis, but the DCT may not pick up those antibodies. And that's a common cause of DCT negative AIHA. Sometimes you may have a situation in which the antibodies are, there's a spectrum. If the antibodies may be directed against the mature red blood cells or against reticulocytes or against the RBC precursors within the bone marrow. Okay, so in that condition, you call it as a pure red cell aplasia. But if the antibodies are directed against mature, the late normoblasts or the reticulocytes at that level, okay, what will happen is you will have hemolysis. You'll have a drop in hemoglobin, but you will not have the DCT may not come positive because the retics themselves are destroyed. You will not have enough RBCs in the blood at all, and therefore those they may not get coated with antibodies, and therefore the Coombs test may come negative. So you have a hemolytic anemia, but you don't have clear-cut DCT positivity. So often it is said that in the former condition where there are certain other mechanisms, certain other laboratory sort of modifications that you can do in the laboratory to make the DCT more sort of sensitive. Okay, we don't do them routinely, and more often than not, if you suspect that there is a hemolytic anemia, you strongly suspect that it is autoimmune in nature, you've ruled out all other possible causes of hemolysis, then we often give a steroid trial. And that's one of the ways we sort of diagnose it. If there's a good response to steroids, then there can't be any other cause of hemolysis. It has to be an autoimmune hemolysis. So response to immunosuppression would give us.
Sir, one of the question again is, when do you do bone marrow biopsy in hemolytic anemia? Do you need to do that in the diagnostic approach anywhere?
Just repeat the question again. I couldn't hear properly.
Just is there any need of bone marrow study in case of autoimmune hemolytic anemias?
Yeah, good question. So I would say if you see a patient who's bone marrow. There are some hematologists who would do a bone marrow regularly. So, for example, my senior Biju George in CMC, he would do a bone marrow for all patients of AIHA. Why? Because you don't want to miss out a low-grade lymphoma in the marrow, which can commonly cause AIHA. So, if I see a patient who is young, as in under, say, 30 years of age or so, 30 or under 40 years of age, with a very typical warm type of antibody hemolytic anemia, then I probably wouldn't do a bone marrow. Okay, I would probably just screen and see whether there are any lymph nodes with basic imaging, and if there are no nodes and all, I would probably think of if it's come very acutely, it's less likely to be associated with lymphoma. But if it is an elderly person, then on the older side, then there are any other features to suggest that there could be lymphoma, I would do a bone marrow biopsy. Bone marrow is not used to diagnose AIHA at all. You don't need that, but as to rule out a secondary cause such as lymphoma, you need to do a bone marrow.
Okay. Kirtan, do you want to ask something?
No, sir, thank
you. There is one question. Evans with DCT3 positive responded to steroids and azathioprine and patient was discharged. After 1 month, again presented with relapse and now refractory to steroids. USG shows portal thrombosis. So what would be further line of management? What could be cause of thrombosis? And will you give anticoagulant? What will be your choice?
Yeah. So this, as I told you, rituximab is my drug of choice in these cases, and I would treat the AIHA with rituximab. USG showed portal thrombosis. So remember that So one thing is you must just sort of rule out whether this patient has SLE, and in addition, or whether the patient has anti-phospholipid antibodies as well. That I would definitely do and see whether there are concomitant APLA. But remember that all hemolytic anemias where the red cell membranes are being broken, and the anionic phospholipids are being exposed to the blood. They are all causes of these are all thrombogenic states, and therefore thrombosis is known to happen in many of the chronic hemolytic anemias. So that also could be one of the causes of portal thrombosis. But I would look for APLA also. An anticoagulant of choice now for whether it is splanchnic venous thrombosis or cerebral venous thrombosis, I use only NOACs. Unless if it is a florid APLA. In APLA, you have to use warfarin. But in any of the thrombosis, including cancerous thrombosis, I would use one of the DOACs. Anyone, whatever you like.
Okay. I think there are no other questions. And one last question from my side. When you suspect the PNH, you do the flow cytometry, and there is 1% or 1.5% cells which shows the positive absence of that feature. Would you consider it as a PNH?
Yeah, so you would consider it as a, you will not call it, you will not, if this patient has hemolysis, he can't be hemolyzing because of PNH. I would say that he just has a PNH clone. He doesn't have florid classical PNH. So in PNH also there is a classical PNH, and there is PNH associated, a PNH clone associated with other conditions such as aplastic anemia or MDS. So I would say that the patient has a PNH clone only. I wouldn't treat him with the what should I say, with the regular treatment for PNH.
So we will still try to find out the cause of hemolysis in such patient.
Yeah, absolutely.
Okay, sir. So I think there are no other questions. So I think thank you, sir. Sandeep sir, do you want to say something or addition?
Thank you very much, Samir, for sparing 2 hours.
My pleasure.
Hopefully now we meet actually.
Absolutely. We must meet personally in Ahmedabad. I would love to come.
Yeah, we'll invite you in next meeting. As soon as I think all are afraid of third wave. Nobody.
Yeah, I know. Yeah.
Okay, sir. Thank you. Thank you all the participants for joining us. Thanks, Kirtan. Thanks, Manan. Thanks, Siddharth. Good night, everyone.
The next, announce the next.
Yeah. So next topic will be by Dr. Sachin Jadhav, and that would be the approach of the hypercoagulable disorders. And that will be on 18th of August. That will be again on Wednesday, 8:30 p.m. Thank you. Thank you, everyone.
Okay.
Thank you, sir.
Thank you.